Cool. Okay, we will get going then, guys. I think the majority are logged in now, which is good. So yeah, welcome to session 2 of week 5. So we've been looking at the focusing on the hip and the pelvis as the main site of the case for this week. Yeah, like I said, I can't believe it's week 5 already. If some of you are new to this, then hello, my name is Mike. I'm the Education Director for Movement Therapy Education. I also teach for Rock Tape, as you may have seen a few times, me wearing my Rock Tape gear. I've been teaching with Dan as well, Dan Lawrence, who's the Education Director for Rock Tape. On a Monday night as well at 8 o'clock. So we've changed that now from a tendon talk into a clinical chat. Hey Natalie, good. Yeah, so we're open to questions basically. So we had a question the previous week about clinical tests and which ones are good, which ones are not so good, and so we put together a session on sensitivity, specificity, validity and reliability. So that those are the measures that we use in scientific research for evaluating clinical tests. So the tests we do in clinic. And yeah, so if you want to have a look at that, that's on the Movement Therapy Education COVID page. So if you type in, I'll just pop it in the chat box. If you type in at MTECPD into the Facebook search bar, then that will come up with our Facebook page and all of the previous sessions we've done, that those will come up on there. Okay, bear with me a second. Sorry, I've just had one more message come through. Bear with me a second. Cool. Yeah. So, yeah, if you're struggling with getting the links for this evening's session, it's basically the same as Mondays. Okay. So we use the same link for all 3 sessions. And then on the Monday, so next Monday, I'll post another one, and that'll be the same link for the whole week. Okay. So it saves you re-registering for things again and again. Cool. So yeah, we're clinic wise, obviously we're closed, and but we've been doing more and more online consultations now. So if anybody's got any questions about how we conduct those, okay, thanks Peter. How we conduct them, and the kind of the issues that we've had, or if you've got any worries about doing them yourself, then maybe that's something we could cover on the Monday session. So yeah, if you've got any questions about those kind of things, then happy to help. And just pop the questions on the Facebook page, and then we'll create the content for you. Okay. So some people have been asking as well about recommendations for books. So I have, this is a obviously I'm biased, but this one here, I'll just pop it up on here. Just so you can see it. So it's that one there. The Routledge Handbook of Sports Therapy, Injury Assessment and Rehabilitation. It's edited by my good mate Keith. Keith Ward helps me out with the anatomy visits when we go to the universities. And I used to work with him at University College Birmingham as a lecturer there. And as a lecturing team, we wrote this book. So I helped write chapter 2 of this. And what we tried to do is create a book that was as evidence-based as possible. And bearing in mind, I think this was about 2016, maybe this was published. So it's about 4 years ago. And it took me nearly 4 years to write finish off my chapter. So already things are out of date when they're in books anyway, but we edited it and we updated it just before it went to print as well. So it was as up to date as possible. So yeah, if you're after oh, cool. Brilliant. Really good, Natalie. Yeah. So if you're after a book for a university degree, then this is a really good book to get, because it's got we wanted basically a one-stop shop for our students, so they could buy one book and then that would sort them out for everything. So yeah, you can have a look at that. I think there's an ebook version as well now. And I wanted to let you know as well, which is really cool, because they've been doing this in the US with the Rock Tape guys, and we've now organised some dates with the UK team as well. So I'll just pop this up for you. So if you think anybody might be interested, if you've never done taping before, we've devised an online taping course now, and it's going to be very interactive. So we'll create our own little Facebook group. You'll be given tasks to do, and we're going to run the 1-day course over 2 weeks, and they're going to be short sessions of an hour and a half for each session. Okay, so we're going to do, I think it's a Tuesday and Wednesday 1 week, and then the following Tuesday, Wednesday. So that, yeah, we'll show you things, and then you'll have to video what you're doing, put them into the Facebook group. It'll be a private group just for our course. And then we can have a look at your taping techniques, and then give you some tips when we revisit you again the next time. So we've just adapted the course for online. So if you need a refresher, or if you've never done taping before, then it may be an option for you to get some CPD in whilst we're in lockdown. So our case history then. We've got Mrs. R this week, and she had a problem with her hip and groin area. So hopefully you should have picked out some key points from the sieve. So that's what I'm going to go over today. I've said this before, but what I would do is the history, I would go through it with a highlighter. So that's basically what I've done. I've just underlined things and pick out key points from the sieve to then form an idea about what's going on with this particular person. So first appointment, sifting through the sieve. We're going to have a look at the start of the objective assessment planning now. Okay, so I'm going to give you a few things to have a look at between now and Friday. Okay, so hip pelvis scenario, again, no right or wrongs, as long as you can justify what you're doing, and that's the sieve. So if you've not seen that before, if this is your first time, that's the sieve. So it should be available to download now, so you can use that yourself with your clients if you want to, or with these sessions. So completely up to you. Okay, cool. So these were the key things that I picked out. So she's 65 years old. That already is going to, hopefully, should in your mind make you think about some of the conditions that 65-year-old women are more susceptible to than younger women or 65-year-old men. She's been a teacher for 35 years in primary schools. So have a think about her job, what kind of environment she's in, okay, and the kind of day-to-day biomechanical issues, if you like, may come about from teaching in primary schools, especially for that long. So she's been on a long holiday in Australia, and I think it was Kay emailed me earlier, and we're talking about DVTs. So we're going to have a little bit of a chat about that later on. So that's a good thought with this one. 5'3" and she's 13 stone. So if you have a look at that on the NHS BMI scale, then she is considered obese. She will admit she's a heavy smoker. Okay, so think about the conditions that may arise from being a smoker, and then fatty foods as well. Lots of fatty foods in her diet. So what could that potentially affect? And I guess the question there is, or the things that you need to have a look at, is how do you metabolize fat? So how do you break down fat so that you can use it as a fuel? What body systems are being used? Okay, so that's something to think about. What organs are being used? Have a think about the endocrine system. So the enzymes that are used as well in the breakdown of fat. She's reported that she's very tired and has been for the last year. Okay, so what things make you tired other than just being very busy at work? but what things medically can make you feel tired, and why might you feel that way. So this is a bit of a worry, this one. So we've got a constant deep ache in the left groin or inguinal area. Okay, so around the front of the hip area. Now this is an interesting one. So if just move that down a bit. So if someone complains of pain here, that's where your hip is. If someone complains here, yeah, that's not where your hip is. That's where your glute is. So quite often you'll see that with patients, and they'll say, "Oh yeah, I've got a real problem with my hip," and they'll actually rub the outside of their legs around the greater trochanter area, and that's not where the hip is. Yeah, the hip is in the groin area. What patients would usually describe as the groin. So have a think about that. And lower lumbar spine located to the left. Okay, so there's something going on this this left region. Are they linked, or are they two separate things? We don't know. We can just justify our thoughts. So the pain also spreads into the left gluteal area as well. So it's going into that kind of lateral hip area. I've said it there, lateral hip. So yeah, the lateral aspect of the upper thigh. So the left thigh, upper leg is feeling dead all over and painful. Okay, so again, have a think about what could be making your leg dead all over. Okay, usually that is a blood supply problem or it's a nerve supply problem. Okay, so usually we've got sensory changes from the nervous system, or we may have some kind of problem with the blood supply. So it's like when you sleep on your arm and your arm goes dead, yeah, and then you shake it about a bit and then the blood comes back and then it starts to come back again. If you have a problem with the blood supply, something will feel constantly dead. Okay, so have a think about what blood vessels that might be, and we touched on that a little bit on Monday's session. So I've been trying to create my own dermatomes. So excuse the writing, my writing's terrible, but yeah, these are some that I put together a little while ago. So these are the dermatomes are the sensory areas that are supplied, if you like, by certain parts of the nervous system. So if we have a look here, we've got so this is the front of your leg, so kind of lateral, just underneath the ASIS area there. So that's that area there, the sensory part of that, the skin part, skin sensation is supplied from the level of T12. Okay, so around that area there's T12. Then we've got these bits here, okay, or around that inguinal area. These are supplied by the lumbar plexus, so the higher area, so L1. Then we've got down the side of the thigh here. This is the lateral cutaneous nerve. We talked about that a couple of times, and that's again lumbar plexus, but specifically usually L2, L3. Okay, there are some crossovers and some differences with these. And then you've got intermediate and medial cutaneous nerve as well. So it's the same supply, 2 and 3. And it spreads across the front of the thigh. Yeah, so all of that region is supplied by L2, L3. All right, that may be a clue to the problems that you've got. Okay, cool. Let me show you. Thanks, Peter. So around this area here, so that is, thank you. Forgot you couldn't see that. So that is where the subcostal nerve comes down, and you get the skin sensation from T12. Right, and then this area here, so this whole region, all around there, all around there, that is L2, L3. So that's the lateral cutaneous nerve, that one there. Then you've got an intermediate cutaneous nerve or femoral cutaneous, and then a medial. And they're all from the same nerve root, L2, L3, L2, L3. So they supply the front of the thigh. And if you have a look around the back as well, no worries, mate. Sorry about that. Yeah, if you have a look around the back, so this is the picture posterior aspect. That bit there, that's all lateral cutaneous nerve as well. Yeah, so that region there. So that's the region where she's getting her symptoms, and that is that where that region, that area of skin gets its sensory feedback through. Okay, so you've got sensation of the skin, and then those sensory neurons then come back into the spinal cord at those levels. Yeah, so if there's a problem at those levels, you will have a strange feeling in that region of your leg. Okay, so it could be that potentially. Cool. So we've got buttock and groin area has been present for the last 2 weeks, so she's not had it long, but the dead feeling has been there for 2 days. So it may be linked, maybe two different things, but whatever she's been having for the feeling of deadness in the last 2 days, that may indicate that something has suddenly got worse. Okay. We've got lumbar spine pain, been a feature for 10 years. So is this one of those red herring things where they go, I fell over in the 80s and my back's not been the same ever since. So is it a problem? Is it a degenerative issue, or is it a bit of a red herring? All right. So that's what we need to work out. Is it linked to what we were just talking about? So maybe the sensation of the thigh, but no idea. Okay. It's up to you to justify it. So the recent groin pain seems to be a fairly rapid onset, coming on immediately after her holiday. So I think that's where Kay mentioned about DVTs. So there is something, let me just show you this. A GP friend of mine told me about this, because I never got taught this on my osteo course, but this is really, really useful. Let me just share this with you. It's called Wells criteria. So Wells criteria for DVT. So if you search that out, I'll put the link in the chat box so that you guys have got it. There you go. That's the link for it there. What you do is basically you go through these checklists. So do they have active cancer? So have they had treatment within 6 months? And if they have, then you tick yes. Have they been bedridden for more than 3 days or had major surgery? Yes or no. Is their calf swelling more than 3 centimeters compared to the other leg? Yes or no. And then what it will do is it will calculate the risk when you finished all the questions. So you've got a score with this one, because I've only pressed a couple, of 2. So you're at moderate risk for DVT. So then you see the next steps below. And the next steps are, it's meant to aid clinical decision and not force management, which is fair enough. But if you're, if you're getting 2, then you need to, here we go, score of 1 to 2, considered moderate risk with a pre-test probability of 17%. So these patients should proceed to high sensitivity D-dimer testing. Okay, so they should be sent off straight away to have blood tests, because when you've had a clot that's formed and then broken off, the D-dimer test will pick up the chemicals that are in the blood after that break off. Okay, so something, like I said, was from a GP friend of mine, mentioned it to me. So it's it's another nice tool that you can use to safety net yourself. So if you think someone might be at risk of a DVT, you can fill in that Wells score, and then you've got clear evidence then of what to do. Okay, so it will tell you what to do. I guess with anything like that, it's if you're at all worried, then you get them off to A&E anyway. Cool. Yeah. So she seems to think that the pain in the groin area is associated with the long journey. So again, we've got this kind of like, is it something to do with this flight? We hear about economy class syndrome, and especially a long flight to Australia as well. Spine pain early in the morning. Okay, what's that indicative of? So if you have joint symptoms early in the morning, first thing, but then easier when walking around, okay, what's that indicative of? What kind of symptoms might that be? She's usually pain-free by lunchtime. Yeah, so it's taken a little while for it to ease off. Leg symptoms get worse if she needs to exert herself. Okay, so again, we've talked about this a couple of times on the previous case histories. When you exert yourself, your muscles need a supply of oxygen. If they're not getting the oxygen, then those muscles will start to fatigue and they'll become sore. Okay, you'll get pain in the muscles, you just won't be able to use them. Okay, so she's also waking up in the night with pain. Yeah, that's not good. That's a red flag there. Difficult to get comfortable on the sofa or chair. So what is it about being in that seated position that might be affecting the things in her legs and her groin? Okay, have a think about that. Just a couple of clues for you. I didn't highlight anything here. Sorry about that. Let's have a look. So we've got this problem that she's had with the GP in the past. So the examinations and treatments, had a difficult experience with the GP, so is reluctant to see them. So we don't, obviously we've no idea with this case. We haven't got the opportunity to ask her, but we don't know how long it's been since she's seen one. So her health might have been deteriorating for a long period of time, and we've no idea. Okay. So mother is alive. Father died of cancer when he was 60. That this was a key one, actually. So she remembers he was an unusual yellow color when he was ill. So what yellow color of the skin is called jaundice. And what can make you have jaundice? All right, so have a look at that if you haven't seen that before. Diet wise, 6 cups of coffee with cream. So most days. So what effect will that have on her body, considering all of the other things that she's got going on with her system as well? Okay. And here another thing to highlight, so breathlessness on exertion. So she's getting pain in the leg, which is worse on exertion, and she's getting breathlessness as well. So are the two linked? Okay, potentially, maybe that's something to think about. She's also suffered with varicose veins for years. So what does that tell you? Okay, what's the state of her cardiovascular health? It may be a hereditary thing, but it may be that it's something to do with her lifestyle that has exacerbated the issue. Okay, she loses control of her bladder when she laughs or when she coughs. Okay, so is that just because of her age, and that's just something that may happen, or is it something to do with the symptoms? That's, again, we don't know. It's something for you guys to have a think about. Okay. This is a real big clue. It says we got intermittent pain in the right upper quadrant. So that's on the patient's right hand side. Upper quadrant is just underneath the ribs. Okay, so the right upper quadrant of her abdomen, and this has been a feature for 6 months. So she's had a problem here for 6 months. Is that something to do with everything else, or is it something different as well? Okay, cool. So again, what I've done is copied from last week, really, and because I used to put my justifications in here, but I want you guys to have a think about it. So some of the clinical impression things I've put down, we've got cardiovascular disease. So why do we think that? What in the case history indicates that? What kind of symptoms? What from her story can you get? Cancer. So why? Where? Okay, what in the history, again, indicates that it may be a tumor. COPD, so a chronic obstructive pulmonary disorder or disease. Why might she have that? What in her history makes you think that it might be COPD? An arterial occlusion, okay, maybe a new word for some of you. So have a look at that. What is it? What causes it? What kind of symptoms might you get? And then we've got femoral nerve compression. Okay, so have a look. What's the pathway of that nerve? What's the pathway of the femoral nerve? Why might it be compressed? Okay, so what in the history may lead you to think that may be an issue? Okay, so just a couple of snippets of things for me to get you on your way researching things. So I'll upload this video as soon as it's downloaded from Webinar Jam, and I'll pop it on the Facebook page so you can rewatch it and have a look over some of the history again. So reread the case history, have a look over the video again, pick out the key pieces of information to help you now complete your sieve. Yeah. So by Friday, you should be able to have everything in your sieve ready. And then we'll go through the final stages of the case and what to do, depending on what you think that she had. Okay. So if you want to put your thoughts on the Facebook page, at Movement Therapy Education CPD, MTE CPD. But if you don't want to post them like some of you already have done, which has been brilliant, send them to me and I can either post them on your behalf or I'll give you some feedback just personally. Okay, so that's entirely up to you. So that's day 2 of the case. We've got session 3 coming up on Friday, 6 o'clock. And we'll kind of wrap things up, and I'll do a bit more of an in-depth look, like we did last Friday, on some of the conditions that may come up from this case, and some of the investigations that you might do, and hopefully give you a little bit more of an understanding about what happens. Okay, so yeah, thanks for tuning in again, guys, and yeah, good to see the same faces and good to see some new ones or new names coming through as well. So I'll see you on Friday at 6 o'clock. Cheers, guys. Thanks.